Hi, my name's Hunaiza, and I'll be continuing our discussion of intimate partner violence from the unique perspective of a health psychologist. So far, Zane has provided damning insight into the severe and damaging effects that the experience of IPV has on family units and society as a whole. From the perspective of ClinPsych, it is clear that children are at a vulnerable stage in their lifespan when exposed to IPV and its related traumas, which leads to severe negative impacts on their development. A key example of this is the disorganized attachment that many young victims of IPV and abuse form with their caregivers. This initiates an intergenerational cycle of violence that has significant ramifications later on in life, affecting their ability to form healthy relationships in teenage and adult years. Thus, it is unsurprising that a significant proportion of these children go on to become victims or perpetrators of domestic violence into adulthood, leading to a continued breakdown of family units and perpetuated childhood abuse. So, how does research from the field of health psychology help us to understand the unique background of perpetrators that have been raised in abusive households and become stuck in a cycle of violence? Before we can address that, we'll need to review what exactly a health psychologist is and how they can treat perpetrators of domestic violence. In a very broad sense, health psychology looks at how biological, social, and psychological factors can influence both health and illness. As the name implies, they work on examining the attitudes, beliefs, and behaviors that can contribute to positive well-being or ill health, researching how these factors can be used to improve the healthcare system. As such, they are often intimately familiar with the healthcare system on the whole and are often consulted in the design of public health interventions, often with the aim of preventing particular behaviors in society. However, health psychologists also work on an individual level as clinical health psychologists, individually delivering therapeutic treatments to help resolve their clients' problems. It is thanks to these combined holistic and individualistic perspectives that health psychologists are able to contribute unique insights into the etiology of intimate partner violence in childhood. Children raised in households with domestic violence are not only forced to witness dysfunctional relationships, but are victims of physical, sexual, and psychological abuse and neglect themselves. Growing up in an abusive and neglectful environment has wide-ranging impacts on an individual's health into adulthood, ranging from substance use to psychosocial problems and diagnoses of mental illness. There are a number of explanations for substance abuse by adults with a history of neglect. The first is via social learning in childhood. Often, children in abusive households are exposed to substance abuse by their caregivers. Through a process of observation, imitation, and reinforcement, substance use becomes normalized, an excuse for the abusive acts that follow. The same process reinforces the normalization and use of intimate partner violence. This process is particularly likely to be modeled by sons if their father is a perpetrator of the abuse. There is also a vast body of evidence indicating comorbidity between mental health disorders and substance use. Experiencing a traumatic childhood has, in many cases, been linked with victims developing symptoms of PTSD. Furthermore, diagnoses of PTSD in adults have been strongly tied to alcohol use and abuse as a means of symptom management and suppression. Thus, it follows that in a study of abusive households by Breckenridge in 2010, it was found that mental health problems mediate the relationship between child abuse and substance or alcohol. It is a commonly held belief that substance use leads to IPV, but is there any evidence supporting that? Admittedly, the evidence for the causal link between alcohol abuse and IPV is tenuous. However, there is a wide breadth of research backing the idea that substance abuse acts as a moderator, precipitating or exacerbating violence. This relationship involves both the perpetrator and the victim, both of which are frequently found to have involvement in substance abuse as a coping mechanism for psychological trauma. In some cases, IPV occurs as a result of adult stressors such as marital conflict. Thus, it is understandable that intoxication can precipitate these violent outbursts or increase their intensity. It is clear that unhealthy behaviors such as substance use and abuse have a role to play in intimate partner violence, and so it follows that modification of these behaviors should lead to a reduction in IPV in targeted couples. Successfully addressing the complex issue of IPV requires efforts that target specific risk and protective factors across individuals and their interpersonal environment. Thus, Klosterman and Falls-Stewart developed behavioral couples therapy for alcohol and substance abuse. VCT is a partner-involved treatment for substance abuse which teaches skills that promote partner support for abstinence and emphasize the resolution of common relationship problems. Victims are taught various coping skills to increase their safety and reduce partner aggression when they are intoxicated. Similarly, partners are taught skills regarding aggression management, abstinence, and dealing with relapse. Empirical studies seem to support the efficacy of BCT on IPV prevalence and frequency. Results from a large heterogeneous intent-to-treat sample showed that BCT significantly reduced violence by 36%, with only 12% of the remitted alcoholics from the BCT group reporting a violent outburst at follow-up, identical to the matched non-alcoholic comparison group. Further evidence from two randomized trials conducted by Falls-Stewart and colleagues. In the first, BCT was compared to individual therapy. In the BCT group, only 17% reported violence at post-treatment versus 42% in the therapy group. Mediation analysis from the authors indicated that BCT worked better because it reduced drug use, drinking, and relationship problems. A second similar study compared BCT to individualized alcoholism treatment for the perpetrators, which was also compared to psychoeducational attention control for the couples. All treatments were equally effective during periods of abstinence, but on days of male partner drinking, aggression was significantly lower for the BCT group, with almost a 51% difference. It is important to consider the limitations of this treatment approach. The evidence cited in favour of BCT all uses the same design and thus is limited in power and validity. Furthermore, BCT itself is only designed for low-intensity situational couple violence. It also necessitates partner involvement, which is not always possible and can put the victimized partner at risk. So what can we conclude? Well, childhood abuse and experience of IPV leads to negative health outcomes like mental illness. Some children then resort to substance use as a coping mechanism. The substance abuse goes on to moderate the intensity and frequency of episodes of IPV into adulthood. However, BCT can address IPV by looking into the individual and interpersonal factors that govern it. However, there needs to be enough empirical support for the treatment before it can be implemented. I will now pass it on to Marina to wrap up the presentation with a discussion of the neuropsych perspective of IPV.